The topic for discussion is examination of comatose patients. Coma is actually a state of unerosible or unresponsiveness. Comatose patients usually are unerosible and they does not have proper responses either in the eye movements, verbally or on motor responses. Coma is actually can grossly be divided into two forms, that is medical coma, medical professionals induced coma. That is, coma is actually in patients where treatment for better healing in a nice environment so medical physicians usually induce coma, but another coma is also present which is beyond the medical conditions, that is where because of any trauma or because of any cerebrovascular accidents patients enter into coma, which is actually a state of unerosible or unresponsiveness. There in coma, there is an alteration of the arousal which includes a spectrum of abnormalities that ranges from being alert to being unresponsive, that is nothing but comatose. So when there are various levels of consciousness, and based on these levels of consciousness and the one of the level of that level of consciousness is again comatose, that there is no arousal despite vigorous stimulation. So what are the various levels of consciousness? Alert is where the state of normal awakeness or normal responsiveness in these patients. Lethargic patients are usually easily awakened and they even with the mild stimulation, and they respond well to all the communications which we give, all the commands, and they can maintain arousal. And one condition of level of consciousness is somnolent. In this somnolent is the voice or touch can arise the patient here. The patient usually awakens and follows the command properly. They require stimulation to maintain that arousal here. And we have something called as obtunded or stuporous. Stuporous level of consciousness is patients are arousable only on repeated and painful stimulus. Here we can see patients are usually unintelligible or they have nil verbal output, and some purposeful movements to noxious stimulus can be seen. Here when we press the patient under the on the supraorbital ridge forcefully, even when with the thumb, or various noxious stimulus when performed on the patients usually have a purposeful movement, but almost nil verbal communication can be seen in these patients, and this is called as stuporous or obtunded level of consciousness. Finally, comatose patients. Here patients will not have any arousal despite of vigorous stimulation. Patients will not show any purposeful movements in this comatose condition. Only posturing can be seen, and also brainstem reflexes are often absent in case of comatose patients. So how do we localize coma? Coma can occur because of lesions at various positions of brain. For example, in diffuse brain dysfunction, it can be because of metabolic encephalopathy or status epilepticus. And in case of lesions of supratentorial structures, here we can see bilateral hemispheric lesions or thalamic lesions, which also can lead to coma. Lesions of infratentorial structures, which are nothing but brainstem lesions, or because of any compression within the brainstem, this can also lead to coma. So these are the various areas where we can actually localize coma. What are the various causes of coma? Why coma occur in most of the patients? The primary reason is most commonly encountered is traumatic brain injury, especially in case of any accidents where we can see traumatic brain injury, patients can land up into comatose state. When there is any bilateral or diffuse hemispheric disorders, in case of any cardioembolism and vasculitis, hypercoagulable disorders, meningitis in case of seizures, brainstem disorders, or cerebral venous thrombosis, these are various etiological factors for coma. Some cases where we can see cerebral abscess, compression, certain medication like opioids, benzodiazepines, barbiturates, tricyclics, even selective serotonin reuptake inhibitors, when taken in overdose, when there is an overdose of these medications, it can also lead to coma. Sepsis, hypoxia, hypoglycemia or hyperglycemic crisis, panhypopituitarism, adrenal insufficiency can also lead to coma. How do we actually evaluate coma? First, history is important. When a comatose patient arrives, take a proper history from the relatives or attendants who have been attending with the patient. Seek historical data from friends and family. Ask for any any history of trauma, recent trauma, or ask for history of any drug abuse or excessive alcohol intake or any drug intoxication in these patients. And do physical examination, check for vitals, airway, breathing and circulation, observe general appearance and behavioral status of the patient, assess the movements of the patient and assess the response to stimuli and response to noxious stimuli if patient is not responding to the milder stimulus. Check for skin and respiration. Why skin is because check for any tracks of drug abuse, any injections of the drugs, and also check for respiration. Comatose patients usually have varied types of respirations. Okay, check for trauma, especially the head injuries if there are any. Evaluate acute and chronic systemic illnesses if patient is having severe hormonal disturbances or any severe diseases such as adrenal insufficiency, hyperglycemic crisis. Evaluate for those chronic systemic illnesses. Check for any drug ingestion, like as we discussed, needle marks, or check for alcohol breath if patient has taken or ingested excessive alcohol. Examine for nuchal rigidity, and this has to be done with care. Neurological examination, here the severity may vary based on degree of impairment. We have to check for level of consciousness, check for pupillary responses with light and eye movements, check for eye movements of the patient, reflex eye movements. Better do fundoscopic examination. Normally when we are checking for eye responses, visual acuity may not be present in severely comatose patient, and sometimes peripheral vision can be checked, that is the visual area can be checked sometimes by suddenly bringing few objects on towards the eye, and there might be patient can respond to those movements again. And check for motor examination, reflexes and meningeal signs. Most of the times coma can be either meningeal because of meningeal causes or non-meningeal causes. So check for meningeal signs. Meningeal signs include stiff neck and reflexing the neck towards backside, and fever can be seen in these patients. And we have various respiratory patterns as we discussed in coma, and some of them include ataxic breathing. Ataxic breathing is something where patient will have, it is again an abnormal breathing status where there will be complete irregularity of breathing, where there will be irregularity of breathing. Sometimes you can have regular pauses in between periods of breathing, okay, and this ataxic breathing can be because of any medullary lesions. Next we have something called as apneustic breathing. Apneustic breathing is something where patient usually have deep gasping breaths. Patient takes very deep and gasping breaths, usually because of any pontine or cervico-medullary junction lesions. And we have something called as Chinese-Stokes breathing. This Chinese-Stokes breathing is again an abnormal pattern of breathing where patient progressively have sudden, they have a deep gasping breath, deep breath will be seen, which is again followed by slower paced breathing. Okay, Chinese-Stokes breathing is again a irregular breathing, and sometimes patient will have deep gasping, rapid breathing, which is again followed by a slow, mild breathing. Next we have something called as slow and regular breathing. This is because of any intoxications of drug or severe hypothyroidism. And we have something called as central neurogenic hyperventilation. The central neurogenic hyperventilation breathing is again very rapid and deep, and it is because of any brainstem lesions. Now coming to the cranial nerve findings, we have to also check for various cranial nerve findings, which include check for pupil size, shape, equality and symmetry, and its reactivity. So for checking this we can use your hanging torch sign, hanging torch test, where we can actually in the dark room check, you put on the light onto the patient's eye and check for pupillar constriction, and check for the equality and symmetry of the pupil of the both eyes. Check for eye movements. An example, position at rest, check for any sudden to and fro movements, that is nystagmus. Check for oculocephalic movements. Oculocephalic movement is also called as doll's eye reflex. This doll's eye reflex, what happens is, normally it is not present in normally well aroused patient. In comatose patients, sometimes what happens is, when we are actually doing the head movements downwards and sidewards, eyelid usually falls down. So they will have a peculiar or characteristic appearance of doll's eye, the doll's eye movement, which is nothing but oculocephalic movements can be seen. And other one is cold caloric testing. This cold caloric testing is used for oculovestibular reflex. Okay, cold caloric test can be used for oculovestibular reflex. Here what happens is we inject cold water into the ear and we check for blink of the eye. Okay, this is called as cold caloric testing. And also check for corneal and facial muscles. And gag reflex can also be tested for cranial nerve findings. Now coming to motor examination, observe the position of the arms and face and various other body parts. Observe how the muscular function is acting. Check for muscle tone and deep tendon reflexes also. And when you are actually testing for a response to stimuli, we see two peculiar postures of in the comatose patients. One is decorticate posture and another is decerebrate posture. Decorticate posture is something, it is also called as mummy baby posture. Here what happens is patients usually have a flexed arms and they have a closed fist and they keep it on their chest. Okay, this is called as decorticate posture, and this decorticate posture in Glasgow Coma scale for motor response can be given a value of 3. Now coming to decerebrate posturing. Decerebrate posturing is something where patient is usually keep their arms and head and neck is been opisthotonus, that is head and neck is stiffened and it is jerked, it is reflexed backwards, and you can also see arms extended to the sidewards. It is usually because of any brainstem damage. Decerebrate posturing is because of any brainstem damage, and decorticate posturing can be seen in case of any lesions in the thalamus or cerebral hemisphere. Now coming to the sensory reflexes, check for pain sensation. Usually patients, severe comatose patients will have less sensation towards pain. However, in mild comatose patients, they usually respond to the noxious stimulus of pain. And also check for biceps, knee and ankle reflexes using a knee hammer. Check for plantar responses. Now coming to the Glasgow Coma scale, which is one of the most commonly and widely used coma scale. It actually tests for eye response, verbal response and motor response. Based on these responses, a total score of 15 is given. If at all the score is between 3 to 8, then it is said to be the patient is under severe comatose state. In the eye response, when patients open the eye spontaneously, then it is plus 4. If the eye open to verbal command, it is given as 3. And eye opening to pain, it is given as 2. And no eye opening is 1. And when it is not even accessible because of any trauma or edema, it is given as 0. Coming to the verbal response, if patient is well oriented to the verbal commands, it is given as 5. And if patient is confused and the verbal response is not proper, then it is 4. If patient is using any inappropriate words, it is 3. Incomprehensible sounds is 2. And no verbal response is 1. And if patient is intubated, then the verbal response can be taken as 0. Now coming to the motor response, if patient obeys to the commands, then it is given as 6. If patient can localize pain, it is 5. If patient have a withdrawal from the pain, it is given as 4. If this is flexion to pain, 3. Extension to pain is 2. And no motor response is 1. Remember the flexion to pain. So patient, we have seen in decorticate posture, because there is flexion, then it is the motor response there can be given as 3. In decerebrate condition, as there is extension, the extension to pain value in decerebrate posture is 2 for motor response. So based on this findings, the total GCS score, that is Glasgow Coma scale, can be given severe when the score is less than 8 to 9, moderate when it is 9 to 12, and minor when it is greater than 13. So the total score can be 15 if the patient response is very good. So this is about the comatose patients examination and Glasgow Coma scale. How do we actually score the patients based upon the responses to the eye movement, verbal and the motor responses. And based on the Glasgow Coma scale points, we can also score again, grossly divide the patient whether he has severely comatose or moderately comatose or minor comatose condition. So this is all about examination of the comatose patients. Thank you.